try that. Oh, that's loud. Good afternoon, everyone. We're so glad that you're here today for this great Alzheimer's disease conference and training program. Before I get started, let me ask, for how many of you is this conference the first time you've come? Is this your first year? So a lot of newcomers this time. We hope you'll mark it on your calendar for next year too. It's in February each year, and we're so glad you're here. I'm April Henkel, and I'm a volunteer for the Alzheimer's Project, and I also work for the Florida Healthcare Association. This program that you're attending now is called Research Update, and our speaker is Dr. Alice Pomodoro, and I'd like to tell you a little bit about her. Dr. Pomodoro is a family practice geriatrician who has been actively involved for over 25 years in clinical teaching of medical students, residents, and geriatric specialists. She is presently a professor in the Department of Geriatrics at the FSU College of Medicine. She previously served as the Director of Geriatrics at Akron General Medical Center in Ohio and as Medical Director of 2 dementia special care units over the past several years. She currently sees patients at the Wound Healing Center and also serves on the Alzheimer's Project Board of Directors. And with that, please help me welcome Dr. Pomodoro.
So let me see, has this mic kicked in? Can you hear me okay? No? I have a little one here. So can you hear me in the back? Yes? No? Okay. Well, how loud can we go? Is that any better? Okay. I got some hands up front. And that I don't think I can max it out any more than that, so I apologize if I can. So welcome. This is the research update, and what we do every year is sort of give you some basic information to help us all get on the same page so that we can understand what some of the research projects are that we're talking about with this. And so I'll be going through probably 7 or 8 different kind of categories of things. But so first we'll start out with some of the mechanisms, some of the things that you heard Dr. Hill also refer to, and let you know what some of the ones that are currently going on, some of the ones that are currently enrolling people in studies in different locations. So this definition of dementia is one that was adopted with a newly revised manual that is formally used for diagnosis and when people are submitting to insurance and things like that. And there are several key features in it. This is the general category of dementia where it's progressive. It is not natural, so you weren't, say, born with it like someone might be born with cerebral palsy or born with a disorder. It's one that you acquire over the course of time. It's in one or more areas of memory, planning, language, those types of abilities. And the key thing is that it has to be severe enough to interfere with everyday independent activity. So if you have just a little bit of something going on, that would put you in a different category if it didn't really affect what you did in your day-to-day life. This is where there's a problem in one of those functions that is sufficiently severe to actually prevent you from being able to do something that you would normally want to do. And someone who knows you is worried about you and is able to view this from the outside because we don't always see these things about ourselves, and someone has actually given you a professional clinical assessment. So it's not only based on the opinion of someone who knows you well, but also you've had testing, you've had evaluation. And that's what allows someone to be given the diagnosis of dementia. Now, there are several kinds of dementia. And the reason I put the red circle here is because it shows you that one kind. What comes to most people's attention first is memory loss, if you start at the very top of this tree. And there are normal and there are abnormal changes. So one of the ones, for example, which is a normal change, is that you'll be talking to someone or you'll run into them in the store and you're having this great conversation and that you know them and you can't remember their name to save your life right now. And so you kind of get out of that conversation and you manage to avoid saying their name the whole time. And yes, I'll see you next week. And then after you get home, about 4 hours later, you go, that was Dolores. Now why couldn't you remember that it was Dolores at the time? Most often it's what's called a retrieval problem, which means that it's there, but it's just taking you longer to find where you happen to store that piece of information. This happens really frequently with older people, and if you think about it, by the time you're 80, you have a lot more information that you've tried to store in your brain than when you were 12 years old. So if you think of the brain like a filing cabinet that's all full compared to one that's only got half a drawer, it takes a lot longer to find where you filed that particular piece of information, and that's called speed of retrieval. Another one that will often happen is, we went to that restaurant, the Italian one that's up on 6th Street, it's downtown, no, it's not a chain restaurant, and you can't remember, and you can't remember. And then the next day, oh, Bella Bella, that was the one. That is perfectly normal. So now everybody who's had that can kind of go, oh, good, all right? Now, if you never remembered it, or if you never remembered that person's name, or you in fact discovered that actually you didn't know that person at all, you were making it up to yourself the whole time, that would not be normal. But that other type of memory difficulty, that's a normal type of memory problem. So then when you're looking at abnormal changes, then you flip over to the other side of that little tree. There's what we call the 3 big Ds, dementia, which is what you just saw the definition for. Delirium, which is the state of being acutely sick. You may have heard the term delirious, like in the old days when someone had a high fever or was in the hospital, they'd say, oh, they were delirious. They were talking out of their head. And that's when someone is sick or toxic from some substance, hallucinating, seeing little green men floating up in the corner, that type of thing. That is not a dementia. That's a reversible problem. It's also sometimes a life-threatening problem because if you don't find out what the underlying sickness is, they could be in a lot of trouble. So that's a different reason for not being able to remember or having thinking problems. Depression and the memory problems that go with that are what we call a lapse of attention. You can't remember something if you never learned it to start with, right? And so the most familiar thing to most of us would be that someone, it could be your mom, it could be your spouse, it could be a friend, is talking to you, telling you something, and you're doing something else, or people are on the phone, until you hear this, are you even listening to me? And you go, sure, and then you close your eyes and you hit rewind play. You just said that, and sometimes you can do that and get yourself out of trouble. My teenagers used to be really good at that. Sometimes you can't. And the reason you can't is because you weren't paying any attention to it to start with. So it never got in your memory. So it's not that you're failing to remember, it's that you're failing to pay enough attention to actually learn it in the first place. And that's what happens when people have a lot of depression. They are not necessarily paying attention, they have low energy, their brains are moving sluggishly, and so they just don't actually learn it to start with. So that can look like someone has some dementia, but it's not actually dementia when you're having that type of a memory problem. So do those things all make sense at this point? Okay. So then if we go back to dementia now, then there's several different kinds. Alzheimer's, as Dr. Hill said, is one of the most common, with about 60% of the time being regular old garden variety Alzheimer's. About another 25% of the time, it's what we would call mixed, with that and some component of vascular dementia, where people have mini strokes and little pieces of the brain are picked off over time so that those areas of the brain aren't functioning as well. And then the rest of the time, it's kind of in this reversible and other category. Reversible just means that when it's like a delirium, but people don't look sick. So if they have a thyroid problem for years and nobody realized they had a low thyroid, then you treat them and everything goes back to normal, then lo and behold, often their memory and their mental functioning goes back to normal as well. Similar kinds of things can happen with vitamin B. But when it's another type of a progressive neurologic problem like Parkinson's, frontotemporal Lewy body, etc., then those are other dementias. So if someone has Alzheimer's, they do have dementia, but not everyone who has dementia has Alzheimer's. Okay? That all make sense? So the kinds of research that we're going to be talking about are going to be specifically referenced to Alzheimer's dementia. Some of the strategies and some of the things we learn may also apply to some of the other kinds of dementia. But what they've done when they try to do Alzheimer's dementia is be very strict about the screening and about the criteria for including people to try and be very accurate about whether or not this affects that particular disease process. So the national plan is a little less ambitious than the Bird Institute plan. They're saying by 2025 that they want to create enough of a national effort and do enough research to find ways to start to treat as well as prevent the actual disease itself, not just the symptoms with it, which means you have to understand something about the causes and the risk factors that lead someone to have dementia, finding it before there's been too much damage. So if you don't find it early enough, you can't protect the brain and you can't get those pieces of the brain back. If you do find it, how do you slow it down so that something else gets you first before the dementia becomes severe? Or how do you stop it at the point you find someone has the Alzheimer's? And if you can't do anything about the dementia process itself, what helps people function the best? What helps caregivers the best? What are the best strategies we have to support people for as long as we can? So Alzheimer's disease itself then causes brain cell damage is the core problem that leads most prominently to memory loss. One of these other areas. So difficulty with speaking, difficulty with caring for yourself, using things inaccurately, like I might think that this was a ruler and I couldn't figure out how to use it properly, or having a personality change. And the personality changes we're talking about are not usually dramatic, like they used to always be a lovely person and now they curse like a sailor and they try to hurt small dogs. Nothing dramatic like that. Usually it's some sort of a characteristic that was there, but even more so, because the portions of the brain which sort of balance our behavior that we keep to ourselves and show to others has now been damaged, and so we tend to show even more of ourselves to others. So sometimes if you see a big personality change, you might wonder what they were hiding all these years. Anyway, underneath there. Then difficulty in abstract thinking, reasoning, judgment, making decisions, understanding why something is the case. And these, again, have to be severe enough to affect someone's ability to function. I do want to give you a little caution about the term mild cognitive impairment, or MCI. Have people heard that term before with it? And sometimes people call it pre-Alzheimer's or pre-dementia. Please keep in mind that it is not necessarily a diagnosis which leads certainly to dementia, first of all. And it's usually only involving one area. That area may not be memory. That area may be something else, like speech or like calculation. I had one professor whose first and only problem for many years was that he could no longer do calculus in his head. Now that happened to affect him in his job and socially. That certainly would not affect me. And I was never able to do calculus in my head. So it is relative to each individual person what their ability level is and what they notice having a problem with. He did not then go on to progress and have more difficulties for a good 7 to 10 years after that, before he started to acquire other problems. So it's not necessarily the memory that's always affected, but it tends to be the one that gets noticed because other people notice it and help let us know that we're having a memory problem with it. So when you hear someone say, well, everyone with MCI will have dementia in 10 years, Don't believe those. Some people can go for a long, long, long time. Some people will never develop it because it depends what the cause of that original problem was. So if it's the kind of cognitive impairment that's related to memory and several other things, and it seems very mild, then yes, those people may be at higher risk for going on to develop more problems later, but it's not everyone. So we shouldn't necessarily plop everyone who has MCI on a medication right now, particularly if they have issues with those medications. So this is just to give you sort of a brief flash of the different portions of your brain that control some of these different functions. So in the front of your head tends to be your CEO, your executive who helps you plan, concentrate, does or does not let certain words out of your mouth at the right time. Okay, speech is kind of tends to be on the side of your heads and just a little bit in the front. Your body functions in terms of your strength and your sensation tend to live up here on the top and on the sides of your brain. Your language tends to be back behind your ears and tends to be opposite to whichever hand you are. So if you're right-handed, your language tends to live over here on the left side. For example, your ability to see is in the back of your head. What goes into your eyeballs gets sent back to the control center there to interpret and to form into an image. All the functions that we describe as being very basic to keep us alive, like breathing, that we don't think about, automatic functions, our senses, the rest of those are tucked inside the outside of the brain in what's called the midbrain. And so those are areas that are not affected as often by any kind of dementia until much later in the game, with the exception of your memory, who not only has some functions out here, but there's also a little horseshoe down at the bottom where a portion of our memory lives. So when we're talking about Alzheimer's, we're not talking about one spot that's being affected. We're talking about a chemical change and loss of nerve cells in the whole brain. When you have a stroke, for example, you only lose it in one spot. And people will often have, say, this left side here where the body controls are, and that's when you notice people having a limp or having a droop to their face. And so you could say, oh, that's this part of the brain. That's not true with Alzheimer's. It affects entire portions of the brain, and it affects it at different stages in the disease. So, to expand a little bit on what Dr. Hill was telling us in her talk, there are plaques, which are those toxic substances outside of the neuron, and there are tangles, which are the toxic substances and the breakdown in the cell's machinery itself. So for the tangle, for example, that is when someone might have more trouble moving blood sugar around and getting it to the appropriate spot inside that cell to use it with nutrition. When you have toxic chemicals on the outside, they tend to cause problems on the outside. So they may interfere with one cell talking to another. They may poison the outer membrane of the cell so that it can no longer take in nourishment correctly and it dies. So the outside and the inside are important because especially if one cell over here dies and then another cell over here winds up having the other cells around it die, it gives up and it dies too. Not necessarily because there's anything wrong with it, but just because it has no one to talk to. And this is a process that actually happens very naturally in children as they grow up. We are born with a lot more brain cells than we ultimately wind up with. But when a child is learning a task, for example, like how to walk, then it requires that a pathway is made and that certain neurons be linked and used over and over and over again, rather than it sort of going the long way or going around this way before it gets to that impulse. So that to be coordinated, you have to have certain things have to happen automatically. So what will happen is that the ones that are used over and over again are ones that stay connected, develop a lot of connections, and become very resistant to being destroyed. All those other ones that aren't needed, that are around it, they don't have any other neurons talking to them, so they die. And they stop being there because being there creates static from them trying to get in on the game with it. So in a child, and as people get older, the skills and the abilities that we have that we use over and over and over again develop a lot more strength and are more resistant to being lost. And that's what we call an overlearned skill. So a good example of this would be verbally, is that if I were to say to people in this room, "Good morning, how are you?" People would generally say, "Fine, how are you?" Or "I'm good, and you?" And we're just sort of like, without even thinking about it. It's not because I really want to hear the fact that you stayed up all night last night when I say, "How are you?" I'm just kind of greeting you to show you that I care about you. And this is, a pleasant automatic conversation that we're having. Whereas having you tell me about your day requires that you invent something on the spot and that you get this part and this part and this part to all work together. So the kind of changes you might see in someone with dementia would be that they can continue to respond very well, very socially in any given setting, like going to the doctor really requires minimal social skills. You go in, the doctor says, "How are you?" "Fine." "Are you having any problems?" In the meantime, he's doing this and this. So you know what the right answer is, right? "So are you having any problems?" "No." "Do you need some more refills?" "Yes." "Well, I didn't see anything wrong with your labs. Your heart sounds fine. So why don't we have you just come back in 3 months?" "Okay." So you can get through a whole conversation with just like 4 words, right? So a person with dementia can get through a whole lot of situations like that without anyone ever picking up on the fact that they're having any difficulty. Whereas if you say to someone, "Well, tell me about your day," a person with dementia might be much more likely to say, "It was good," because they can't remember the whole day and they can't use the language to build the story of the day anymore. So overlearned skills stick with us a long time. The skills that we don't use tend to go. That's part of the reasoning behind that saying of use it or lose it with it. And more importantly, the things we don't use, those cells just go ahead and die. And they keep doing that as we get older as well as when we're younger. And it's a natural process. So as we lose cells, the brain tends to shrink because the cells are actually dying and you don't have as many of them up there anymore. And what that looks like on a PET scan, when you give someone a shot of glucose, and glucose goes to all the cells that are moving around and doing things, on your right, you see what would be normal, lots of colors, lots of brain activity. On the left-hand side, you won't see that brain activity where the cells have died or where the cells are so damaged that they can't use the glucose anymore. And some of this, the idea is to catch people before they look like they do on your left-hand side. To catch people while they're still sort of on this normal looking, but to see where the amyloid is and if they can have something that can be done about it. So to sort of sum her up in a box diagram that's a little less complicated than some of the ones that we've already seen today, because this helps me remember. You have the toxic chemicals outside. That's the amyloid, sort of like the toxic waste dump. You have the toxic changes inside. That's the neurofibrillary tangles. And those lead to changes in your brain structure. Your cells die, they thin out, they lose touch with each other. And then that's when you have brain cell death. Now, when your brain cells die, then they don't make as many chemicals as they used to. And chemicals are to your brain like cell phones are to people. That's how they communicate with each other. So if you're trying to talk to another person on a cell phone where you don't have any Wi-Fi, it's a lot harder for some functions, for texting and things like that. If you're trying to function in a restaurant and you want to use your computer, but there's no Wi-Fi, you can't really do it. Okay? If you don't have brain chemicals running around in between carrying the messages, then your brain can't communicate with itself and it can't do a lot of things anymore. The major chemicals are acetylcholine and glutamate, and there's a couple of others in there, and those are what Dr. Hill was referring to as symptom support medications, the ones which make those chemicals last longer in your brain than they would naturally. Because obviously you don't make some chemical and it doesn't run around there all day, or you'd be having that same thought all day running around your head carried by the same chemical. It carries the thought and then it disappears. And when you want to send another message, you have to make another little bit of chemical to send it over next door with it. So that little bit of chemical has to last long enough to carry the message, but you don't want it hanging around forever, and your body cleans all those up very quickly unless it has a medication to stop it. So when we don't get to communicate and when we want something done, then if I can't tell my memory that I want to get this piece of it out, the memory still may be stored there if that particular cell hasn't died. But if I can't send the chemical message there to get my memory out, then it's stuck. And that leads to some of the cognitive and some of the behavioral changes that we see. So does that whole process make sense? Because when we talk about research, we're going to be talking about which areas are being affected by the research, the good, the bad, the ugly. All right? So plaque-related causes, these are on the outside of the brain. So what gives us more amyloid? What makes a bigger garbage dump? So you have some predisposition. There is a degree to which it runs in families. You can say that when you have onset or diagnosis before age 65. By age 75, it's starting to get into sort of your garden variety. Almost anybody could have this level of risk. So only if your family member has had this occur younger than age 65, and it tends to be in women. And there tends to be also on all these genetic predispositions problems cleaning up the toxic waste dump. So that's on the green side. When you have a toxic waste dump there, then you develop inflammation in your brain. And when you have inflammation, it causes more cell death and it causes more static. And you have more trouble with function. Just like when you have an inflamed elbow, if it's all swollen up and red, you can't bend it, you can't use it. If your brain is inflamed, you can't use that portion very well either with it. Tangle side, there's again another whole set of genetically related ones that predispose people to have these problems. Same reasoning applies, needs to be before age 65. But these tend to be, again, on the inside of the brain. These are the ones that are more associated with nutrition. So the lipids, the glucose, problem moving around inside the brain so that inside the cell so that cell stays healthy and can work. And so a lot of the treatments you see are related to what are called the free radical theories, or superoxide dismutase was very fashionable for a while as an alternative therapy, and they would try to sell great big jars of it in the nutrition stores. That's the theory on this side. So on the yellow side, again, the common pathway for damage is inflammation. So it gets inflamed, it gets irritated because now there's junk on the inside, and so it can't work properly. So again, when the brain cannot talk to its friends, it will die. And if you have a neuron that's trying really hard to talk to its neighbors, it sends out so much static that it can actually interfere with the communication that's trying to go by. And so there's two ways it can cause a problem. One is the missing link. One is that it's causing static for its neighbors and interfering with the problems. So after long enough, if it causes so much static it can't talk to anyone, then that poor little neuron dies as well. So you can have an increased family predisposition on any one of about a dozen different chromosomes. There can be too much toxic waste inside your cells, too much toxic waste outside your cells. You can have problems using energy and glucose in your cell itself, or you can have trouble making chemicals that go between to give each other signals with it. The last one about reception of brain signals is how one of the medications works, but only one at this time. So one of the issues people bring up is this really one disease? And many people think actually probably not, but that we haven't developed good enough tests to separate these two sides out yet, or to separate other things that could be causing it. But since there's sort of a common pattern of behavior and a common time course for this, and it all winds up at this tail end of the brain cells not being able to talk to each other, right now it's all being called one disease. But as you can see, there are so many different research projects and so many different ways to look at this. People are thinking, well, probably we're going to eventually sort out the family kind, the nutrition kind, and some of the other kinds that are involved. On the good side, that means there's a lot of different things that we can try to do to intervene. So when you hear about a research trial, there are 4 different phases. And it's important to know which phase it's in to know whether or not it's something that's going to do you any good when you listen to it in the news. The first one, or a phase 1 human trial, is to see just whether it's safe. So if they give you this stuff, does it make you sick or not? And that's the total purpose of that. So if you hear that something's in a phase 1 trial, for example, the vaccines that were starting to be tried about 10 years ago had to be stopped because those particular chemicals were giving people encephalitis. And so they had to stop those trials right away because they weren't safe to use for different people. The vaccine that's being used now, it's much safer and much more refined. But again, this is 10 years later. So the mice are somewhere below this. There are lots of things that have been proven to save all the mice on the planet from Alzheimer's. Unfortunately, it doesn't translate as well to humans. So information in mice is good, but it's not even up to being tried in humans yet, and that's really important. So number 2, phase 2, larger people. Now we're not just looking to see if it doesn't make you sick, but does it actually work? Does it actually help anything? Memory, function, how your brain looks on a scan, anything at all that we can monitor. And this is where they are very anxious to find blood tests that go up and down with the course of disease, so they can do something a little less invasive and a little less time consuming to see if things work. After that, then in phase 3 is when they say, okay, let's try it on a whole slew of people and compare it to something that we know works and see if it's as good, or compare it to nothing and see if it actually helps. Because these small numbers of people, these are people you pick who have a certain problem, and sometimes you can give almost anything to people with a problem and it will help. Sometimes just because they're getting more attention, sometimes just because the medication and the treatments are being paid for when otherwise they couldn't afford it for themselves. So in a small number of people, you really can't tell how well something works. You need to have it on a larger number of people, and this is why they're establishing the disease registries. Then in phase 4, that's when all of us are the guinea pigs. So they've tried it on a few thousand people. Now it's been released to the public. Let's see what happens. And that's where you get a lot of variability, because obviously the public has a lot more variation than just the people who are screened carefully to be in these tests. If I just want to test someone who has Alzheimer's, that means I don't want them to have heart failure or vascular disease or diabetes or Parkinson's or any of the other things that could cloud the picture about whether or not they're getting better. Because maybe why they aren't getting better is being affected by one of these other diseases. Well, in the real world, nobody has just one thing, right? We all have several different things going on. So in the real world, then when you start trying out something on everybody, then you can see a whole different set of effects, either for the better or for the worse. So right now, with family and genetic research, what they are doing mostly is using known registries of families that have these strong predispositions to it. There is a family in particular in South America that has several hundred members where everyone starts developing signs of Alzheimer's in their 30s with it. And that obviously, they have a very strong interest in preventing this, and also a strong interest in trying any kind of treatment that could help. And this is also a group of people who we know are going to have this, so it's pretty much a good bet that if you're trying an Alzheimer's treatment on these folks, you're trying it on someone who doesn't have some other strange cause. And so people are starting to try to do this. And they've identified these chromosomes where you have a predisposition towards something. And so the question is, can you change somebody's actual genetic makeup to help stop it? Can you go in and cut out that little piece and substitute something else? Can you give some kind of a medication that makes up for whatever is wrong with that particular piece? And if you were a member of this family, would you want to know? And people get into the same kind of issues with ethics like this with, say, ALS or Huntington's disease. How would it change your life if you knew this? Do you want to know now and be concerned and plan, and maybe you would or wouldn't decide to have children? Or do you not want to know so that you can go on and have a normal life and not be scared for as long as you can? So there's a whole bunch of ethics that go into doing family and genetic research as well with it. Right now, there is only one genetic modification study underway called the CR110 study, where they are actually using a virus to transfer a gene to the brain. And so there are people who have mild to moderate Alzheimer's. I have 50 patients. Half of them have had this virus injected into their brains to see if it can help protect the brain against the damage that's being caused. And what's being injected is a growth factor. We don't usually grow more brain cells very easily after we reach adulthood. And so this particular growth factor is a human growth factor, and they're injecting it to see if they can stimulate more brain cells to grow and defend themselves against the ones which have been damaged through Alzheimer's. The other folks had a placebo injected in their heads. So you can see this was probably kind of hard to get people to volunteer for this study. And they did do a phase 1, so that was the remember whether or not people are being damaged study. On 10 people, seemed safe, seemed to work, didn't hurt anybody. So now they're going ahead with this would be considered a phase 2. It finished in March of 2013, so they finished giving people the shots then. Then they're following them for 2 years to see how it affected them. They just finished this a year ago, and they just finished the testing of those people within the past 6 months. So now they're trying to analyze all the information, and it should be published soon whether or not this actually was found to be helpful for people. Along those lines, in terms of prevention then, this is another biological or an injectable substance, but it's not directed at the genes. This would be similar to the kind of shot that people get after they've been exposed to hepatitis B. So you can have a shot beforehand that teaches your body how to defend against it in case you get it. That's what most of the shots are like that we get as kids. Have this shot so that when you run into this germ, you can kill it and you won't have to worry about it. What these antibodies are what's called passive protection, which means that this is an antibody that goes in, tags the amyloid so that your body recognizes it and it can get swept out. So the body doesn't have to already know how to defend itself. It will naturally defend itself because of this substance that's sweeping it out. And so these are people from this registry have enrolled in this, 100 of the people from that family. And it is in the phase 2 trials. So it's being tried in several people to now see if it actually works. This requires a weekly shot that these folks are getting. And they're following these folks for at least 5 years because these people were recruited in their late 20s, and they know that onset is somewhere between the age of 30 and 40. So they are trying to follow them out to age 40 and see what happens to the people who received the vaccine and the people who did not with it. But so far, it's not causing problems with the encephalitis, et cetera, that we saw in other people. So that's where the genetic side is on those 2 chromosomes, those 2 branches that are coming in. In terms of then, say you're over here, and you can't really do anything about your genetics right? So you've got your brain cells, and what you need to do is to try to preserve them for as long as you can. What the brain training theory of prevention is that if you train your brain a lot, you give them those overlearned skills, and you keep having them make more connections to their neighbors, the more connections you have and the stronger they are, the longer it will take you to lose them. So it's kind of helping your brain be conditioned to last longer than the dementia process is what it basically is. It will take, for example, a natural athlete much longer to become too weak to lift a 10-pound weight than it would take me, or than it would take an 80-year-old who wasn't staying in shape. Same kind of principle of conditioning for the brain. And that's also the reason that when they've had education studies, the higher your educational level, the more protective it is, mostly because you've been making those additional connections and using your brain for longer. So the more connections you have to lose before you start losing some of the ones that are vital and that will show up in your everyday functioning. So there's a little bit of mixed results on this. For reasoning, so your ability to solve problems, and for that speed of processing, how fast can you get that piece of information back? How long does it take you to solve the problem? Those, they gave people 2 sets of trainings, 5 years apart. They didn't give them any other practice in between time except whatever people may have chosen to do on their own. And then they checked them again later down the road. And they did find that people did keep skills in those 2 areas. The downside is that just those 2 interventions did not seem to change the risk of dementia. So the question would be then, well, what sort of dose of training or what sort of dose of education might I need to help protect my brain against losing its connections? And the other question would be, well, gosh, if there's these other 7 things that can cause dementia, and I'm only doing something about this one piece, maybe that's not enough. Maybe I need to be doing something in several different areas to help protect my brain against dementia. So there are ones using computer training, which are the most popular, and also one which is measuring whether or not people are able to do different activities better. And aside from healthy people, they're also now doing some of these in people with mild to moderate dementia who are able to cooperate in the studies. And they're going to be following up that and see whether or not function has improved in particular. And those results are supposed to be out starting next year with it. So these are variations on different ways of engaging your brain. So the ones which combine physical movement, social activity, and a cognitive skill that's new that you're learning, like a pattern, seem to be the ones that are the most effective. So acting and theater involve all those things, memorizing a script or a pattern, interacting with another person, and physically moving around a stage. Musical performance for a musician, and also ballroom dance tend to be the most effective from those points of view. In terms of regular exercise, and what we've been hearing a lot, what's good for the body or good for the heart is good for the head. They have started to study these in people with that MCI who might have a higher chance of progressing down the road to developing dementia. There are 7 trials, 3 of them are done, and they're doing the follow-up testing now. And they have different kinds of physical activity. The ones which are most likely, again, to be of most benefit are those which involve dance or choreographed dance to music in groups. So Golden Zumba participants, that's a good route to go. The ballroom dancing route, that's a good route to go. But in any case, you do want to have your goal of 150 minutes a week broken up. You can break it up into 10-minute segments if you want. 10 minutes 3 or 4 times a day for more days than not. But that 150 minutes a week seems to be the threshold with it. Then the other one, of course, is diet. And The decreased likelihood of progression has now been found in a very long-run study called the Framingham study, which has run for about 30 years, where people who tend to follow a Mediterranean diet were shown to have a decreased incidence of problems, as well as some specific studies which have been done in European populations. And so this is one of those instances where you really can say the heart-healthy diets are very similar and probably do help. One of the thinkings is that the olive oil and the lower alcohol levels are again providing an alternative type of fuel to your brain that it can use even after it's had some damage with it. Now the antioxidants, those are ones which are intended to clean up the garbage dumps inside the cell and prevent you from accumulating those tangles and garbage dumps. So the vitamin E showed some improvement in actual function, which is the first time that that has been found. Used to be vitamin E showed less tangles, but people still acted the same. Now they are showing that there was an actual improvement in function, and there's another very long-running trial of several thousand people called Pre-Advise, which was originally designed to study other things like cholesterol and blood pressure, that they're still waiting on results. Resveratrol, Dr. Hill also mentioned, and this is one that cleans up the antioxidants, helps decrease, it is an antioxidant, I'm sorry, it cleans up free radicals and it helps decrease inflammation in the brain. So grape juice, red wine. The problem with this is similar to the problem with caffeine, where she said you need to drink 15 cups of coffee. For this, you'd have to drink about 2 gallons of red wine in a day to get this same effect, and then you'd wind up with the toxic effects of the alcohol. So there is a resveratrol. There are 2 resveratrol studies underway right now to see if having the similar substance in a pill format that's concentrated can actually achieve some of the same benefits that they see. So this one is in active recruitment for subjects right now for people with memory problems. And USF is one of the study locations. So this is one which people could enroll in if they're willing to participate in all the different studies. Sleep apnea is related to the free radicals by virtue of the fact that when you don't get enough oxygen to your brain, then you cause increased inflammation and free radicals to run around because your brain is starved from the high enough oxygen levels. And they did find that older women who were, in particular, who were sleep deprived because of their apnea were twice as likely to go on to develop some type of MCI or dementia. So right now there is a pilot study going on to see if oxygen supplementation can help delay the progression in people who have MCI. So they know they have some memory loss, but they haven't developed enough impairment in function to actually be considered to have dementia yet, and see if that can help stop it. This one, unfortunately, is in France, so unless someone's really dedicated or you own your own jet, I don't think that we would be able to enroll folks over there. Then the other thing that I find most promising right now is the diabetes medications, because these are medications that are already out there that have established doses and that we know them to be safe and we know what their side effects are for people. So if we could demonstrate an effect and people could tolerate the side effects, they're already being broadly manufactured and there might help. So to help with this glucose metabolism problem, a unique feature of intranasal insulin is that it actually travels up your nasal nerves and goes directly into your brain. And there's very few other things where you can get stuff directly into your brain. And so they are studying this one called the SNF study, appropriately, for, again, early Alzheimer's and MCI, to see if they can get some demonstration of either stopping disease or improving people's ability to function on testing. They started recruiting for this about a year ago, and they still have yet to get the 240 people that they need. They will not end it until a year and a half afterwards, so they have enough time to see if the insulin's working. So this is one, again, in which people could get enrolled. Exenatide is another one of the diabetes medications, and they will be ending in December of 2018. It's finished enrolling just this year, and so they're just starting their follow-up period. Metformin, there's some variable results, and the pioglitazone and rosiglitazone, which are diabetes medicines, unfortunately, when they were tried out in 2012, they did the follow-up studies and they found that they were not helpful. But the whole idea of helping your brain use the energy and the nutrition that it has better is one that has really taken hold and that people are looking into more. So similarly, with cholesterol therapy, there's also a big controversy about the statins because another study, which Dr. Hill didn't have time to mention, just showed that in Great Britain, the registry of people who were on statin therapy had an increased incidence of dementia compared to the regular population. But you have to also wonder if that has to do with the vascular dementia, because cholesterol affects your plumbing everywhere, whether it's in your heart, your brain, your kidneys, your feet. And so if you're not doing well in terms of your vascular disease, and that's why you're on the statin, chances are is that that will affect your brain, and the statin may not be able to prevent that. So people aren't quite sure about that. In the short term, they haven't shown any negative effects of it, but there's one study where they're trying to use one particular more old-fashioned medicine, gemfibrozol, which is also used for lipids, to see if that will improve people's function. They are about to start their final testing because they expect to finish recruiting, and the people that have been on it are already being tested, but the people who are just joining the rest of this year, they won't have results on for another couple of years. Then the most physical intervention is this deep brain stimulation, which you may have heard of for Parkinson's disease. It's where they implant two little electrodes through the top all the way into that midbrain section, and they send little electric pulses. And it's been used for quite some time in people with Parkinson's or people who have severe seizures to help regulate it. It's sort of like a little pacemaker for your brain instead of a pacemaker for your heart. They found as a side effect that when they used it in people who had those two problems, that their memories improved. So now what they want to do is start using it in people who just have Alzheimer's without any other disease and see if it will also help improve memory. The thinking is that it helps regulate that flow of information to eliminate some of the static that we talked about earlier from the cell death with it. Then there's the vaccines for people who are not in the registry. There are several different names. I have to tell you, they've tried, of the four major ones, two of them have been tried and have failed because of either causing inflammation, causing a secondary side effect like a stroke, or just plain not working at all. And so right now they are recruiting for some people who are willing to receive an injection every 4 weeks, with the fourth one, which is also the one that has shown some promise in the family in South America, to see if that will help people through that phase. It's about a 3-year study, 2.5 years, and that one's going to end in 2020. The catch with that is that these are things which are called biologicals. So when they're manufactured, they're the types that have to be delivered by injection that live in a refrigerator. So they will be thousands of dollars at this point in time until someone comes up with a way to do mass manufacturing. Then finally, in a whole different category of research, there's what are called crossover drugs, which is that some medications that were developed to combat abnormal cells in other areas of the body, like cancer, that work by stimulating your body's own defenses, are ones that can be sometimes used, the thinking is, to stimulate your body's defenses to get rid of the amyloid in your brain. So not the tangles on the inside, but the amyloid, the junk that's on the outside. They noticed that people who were taking this at the time that they had their chemo developed less chemo brain, less forgetfulness, less feeling stupid, less feeling confused as a result of chemo. So again, from noticing this side effect, they're thinking, well, maybe this would also help protect people who have Alzheimer's. Maybe it would help them get their immune systems get rid of the amyloid, just like this is helping the cancer patient's immune system get rid of the garbage from the cells that are killed during chemo. So this one is also still in recruitment. This is one that you could enroll in through USF, and they're giving it to people with MCI, not with dementia, to see if it stops them from going further of developing Alzheimer's. So it's going to be a little bit longer term study with it. They are looking for 2 years of follow-up. As much so, again, the 2017 results are going to come from people who enrolled early on in this particular study. Saracatinib is another cancer drug which is getting a new purpose, and it is blocking a protein that keeps cells from talking to each other. So in that process of the cell losing touch and dying, there's a protein that's made that sort of helps cut off the connection. This drug keeps it from cutting the connection, with the idea that if they can just stay connected longer and talk more, that the disease cell might get healthier again. And they are still recruiting. So the other ones, which are throughout the rest of your slides, the hormones have been around like a really long time and go up in popularity and down in popularity and up and down. The most interesting thing about this is that this is a very old drug, but in mice now, not people, but in mice, it's been found to help people who have had spinal cord damage to grow neurons to reconnect the spinal cords. And it used to be thought you could never reconnect the spinal cord naturally by having it grow together, that once it was cut, it was cut. They have actually started giving this to some humans after a damage, and they're seeing a little bit of reconnection with the spinal cord. So they're thinking, well, maybe if we give this to dementia patients, that it will also help those people to regrow cells in the brain that can then reconnect, prevent further cell death, and establish some new pathways for people to learn to do different tasks. So again, this one's out in California, and they are giving these as an IV. That's the downside of this one, once a week for 3 months, and then we'll be looking to get people to have blood levels as high as those which are seen in pregnancy, because that's how high it takes in a human to achieve a similar kind of effect in the spinal cord. So you can sort of imagine the side effects if you've got hormone levels like people do in pregnancy. We've all heard the phrase acting hormonal for people. So these all have their own set of side effects, but they all also have their own set of potential for the future. So in conclusion, I think those which probably have the most potential right now are the ones which will affect the nutrition side with glucose use and with lipids. Long term, the ones which are able to sweep out the amyloid or to help the body start to regenerate brain cells are probably our next most hopeful, because again, those are drugs, some of which are already known, so they won't have to go through the very, very, very long safety and dosage trials. That pipeline can be close to 10 years. But in the near term, in the main thing, what we can do is in that trio of things that lead to our condition in life. What you're born with, can't do much about that. What happens to you, do you get hit by a truck? Can't necessarily do much about that. But what you do with it, we can do a lot with that, and that would be the lifestyle, the education, the nutrition, and the brain training pieces. So that would be, for the future, that is where the research is pushing us right now. All right, and then I think we'll be having an event to follow after the break, but I can hang around for a little while for questions.
Great. Please help me.